So all the money really is in non-muscle invasive bladder cancer right now, but some updates in muscle invasive, particularly in perioperative treatment. So radical cystectomy is still considered the gold standard therapy here. It's the mainstay of local and regional therapy in the male. As you all know, bladder, the perivesical fat, prostate, seminal vesicles. Not much has changed, not much research going on in prostate sparing. And we're still concerned about local regional control here. So just one single slide and word about open and robotic cystectomy. I think it's becoming an old topic. There's really no difference in complication rates and outcomes. So I think we're moving past this idea that we've minimized the complications of the surgery. There are complications remain. So moving on to neoadjuvant chemotherapy, what's new? Well, there's a lot of trials and I'm not going to go through any of this in detail, but just to show you one of these, the PURE-01 that introduced neoadjuvant pembro before radical cystectomy. So 3 times 3 weekly cycles of pembro prior to cystectomy. This is for organ confined disease. And you can see the pathological response rate here of about 40%. Small trial, phase 2, 43 patients, but nevertheless intriguing and something to talk about. This was presented a couple of years ago, but you're going to see this concept over and over again with either addition of immune checkpoint inhibitors to chemotherapy or moving on to other therapies altogether. So basically taking drugs that we know work well in metastatic settings, obviously moving it to the neoadjuvant setting. I'm going to read through every one of these now. These are just to show you all these phase 2 trials of neoadjuvant chemotherapy in bladder. There are lots of them. Every combination you can think of is there. And also for cis-ineligible patients, we've got lots of trials. And most of these trials are very small. We're basically looking for response rates, and you can easily see that within 2 to 3 months. This is what modern open radical cystectomy looks like. It's an infraumbilical incision. We still do fairly meticulous lymph node dissection. Not a whole lot's changed, but I'll show you one of the data that came out fairly recently. Enhanced recovery protocols are here to stay. They've significantly decreased hospital length of stay, and everybody has some version of it at their hospital nowadays. So in the female, reproductive organs are often removed, but really the risk of involvement is low. So vagina is the most commonly involved site, especially with tumors at the base of the bladder or the posterior bladder wall. But recently, there has been some interest and effort in patients with lower stage disease to do these vaginal sparing and female organ preservation. You can see this is a patient who underwent radical cystectomy. You see the stitches there. You see the anterior vaginal wall getting ready for a neobladder, and the entire uterus tubes and even the broad ligament has been preserved. So this can improve postoperative sexual function. Not a lot of data there, but I think there's more and more effort nowadays to do this. So what about lymph node dissection? We have the king of lymph node dissection here, Seth Lerner. We're awaiting the S1011 trial results, but this did come out. This is not the actual trial, but this was a editorial, essentially point of focus debate written. So this was by Gergen Geschwend from Germany. This was a randomized phase 3 trial, essentially comparing super extended versus a standard lymph node dissection, and it failed to show a therapeutic advantage of this super extended lymph node dissection at 5 years. But I do want to focus on these numbers: 65, the RFS, which was the primary endpoint, 65 versus 59. The hazard ratio was 0.84. When you see none of the p-values are really statistically significant, but if you look at the absolute difference for CSS, OS, they are significant, at least to the eye. So there is a trend towards better survival, and we'll just have to wait and see with SWOG S1011 what this will show. But for now, I think we have not abandoned doing super extended. What about adjuvant chemotherapy? Well, everybody knows 9 randomized trials, about 1,000 patients. There is a pooled hazard ratio reduction in overall survival. I'm sorry, a protective factor for disease-free survival is improved, and it's more beneficial in nodal metastases. Of course, the limitation is these are small studies, they're flawed. But when you put the data together, it does seem like there is some advantage there, and we do need better trials moving forward. However, when you look at immunotherapy, and I'm just going to highlight one single one here, the IMvigor010 study, which will be published soon, which randomized patients for adjuvant immunotherapy in patients who either got neoadjuvant chemotherapy or were not cisplatin eligible. They got either atezolizumab or observation, which is the standard of care currently, randomized 1-to-1. And again, I'm not going to go into it in detail, but just to show you the disease-free survival in the intent to treat population was exactly the same. So unfortunately, this trial that was very well done, accrued all the patients. You see, it's a large trial of over 800 patients accrued, did not show benefit. Now, there are other IO trials, namely the Ambassador trial, which is using nivolumab, and another one, and others too, using the other checkpoint inhibitor. So we'll see what the pooled results will show here. Just one word about other bladder sparing protocols within SWOG. We have the SWOG NRG 1806, which randomizes patients 1-to-1 for concurrent chemoradiation therapy versus chemoradiation plus immune checkpoint inhibitor with atezo times 9, with the primary endpoint being this new bladder intact event-free survival, which is sort of a new endpoint. It basically includes muscle invasive recurrence in the bladder, regional pelvic soft tissue, or nodal recurrence. So it sort of takes into account all the potential recurrences in the bladder. So conclusions, a lot of clinical trials are underway, which is nice to see. Will help define the optimal combinations that we need to do, and also sequences of agents across all the disease settings. We do need better biomarkers to select the right treatment for patients. So I think this is a good sort of a base for further discussion later. So I'll stop there.